Hi, good afternoon. My name is Yasmin Bauer-Ventura. I'm a rheumatologist at the University of Chicago. And first of all, I want to welcome our myositis community to this webinar. I am honored to be here with you today, and hopefully we're going to have a very productive session. So my topic today was to discuss something that was a good, interesting breakout topic for the treatment in the myositis, polymyositis. And I decided to talk to you all about intravenous immunoglobulins and inflammatory myopathies. So you may have heard about this medication as IVIG before, and I wanted to discuss a little more about this medication and why we are talking about it particularly. So again, this session is going to be about 40 minutes, and after that, we're going to have a questions and answers session. So feel free to, record all your questions because we're going to be discussing them after the presentation. So the reason why I decided to select this topic to talk to you today is because IVIG, or intravenous immunoglobulins, were finally FDA approved for the treatment of the myositis in adults in July 15th of this year. So that was very recent. The myositis community got very excited. And I wanted to bring this breaking news to you because it has been quite a while that we don't have any updates from the FDA with respect to our to our treatments for the myositis. I see here in Q&A sessions that there's some questions about ILD. I'm definitely gonna mention about ILD at some point in the presentation. So if you don't mind, Marianne, to stick with us, we can talk about it later during the presentation. So the reason why, again, I would like to talk to you is because IVIG was finally approved by the FDA for the treatment. And this is a huge progress in the myositis community. And this is exactly our reaction. So it is not that often that we have medications approved for the treatment of autoimmune diseases in rheumatology at all. And this is the reaction we get because it takes many years, sometimes decades, for us to see approval of medications such as this one to the treatment of our patients. So the topics that we are going to go over today are, well, what is IVIG, or intravenous immunoglobulin anyway? This is a question that I get a lot from my patients, and I would like to share with you some, basic knowledge about this medication. How does IVIG work, or actually, what do we know about it? And why is everyone excited about IVIG? And what about the side effects, which is something that all providers should be discussing with their patients whenever they are recommending this medication. So before we go into all these details that I mentioned to you in the prior slide, I want to tell you a little bit about IVIG history. So IVIG was in infants in the 1990s, when in one of the most important journals of medicine, the New England Journal of Medicine, there was a publication with just a small amount of patients, 15 patients with the myositis, they had resistant to treatment. When I mean resistant disease, I mean diseases that are hard to control or barely controlled with high dose of prednisone and other immunosuppressive medications. These groups were divided, these patients, 15 patients, were divided in two groups. Group A consisting of 8 patients, and these patients received intravenous immunoglobulin every single month for 3 months in a row. And the group B received placebo. And after those 3 months, there was a crossover. So some patients who had not received immunoglobulins were able to receive immunoglobulins, and some patients who had received immunoglobulins no longer were on treatment. And this article was the first one to actually document in our literature that a decent amount of patients, 9 out of 12 patients who received immunoglobulin, noticed a significant improvement in muscle strength also were more independent in daily life activities, such as going upstairs or brushing their hair, and also noticed improvement of their rash. So overall, the authors of this study in 1993 noticed that, well, it seems the immunoglobulins are safe. No patients in that study discontinue their medication because of severe side effects in patients who had resistant dermatomyositis. And again, when I mention resistance, because the disease is very difficult to control with high dose steroids and other immunosuppressants. And these patients, most of them, 9 out of 12, noticed that their strength improved, their rash cleared, the CK levels, those blood tests that we follow over time in patients with myositis had come down, and there was some improvement in muscle inflammation, and also not only for noticeable by the patients, but also by muscle biopsy. So these patients had muscle biopsies done after they had been through the treatment with IVIG, and there were signs of lesser inflammation in their muscles. So overall, it was a very positive test, positive study, even though only included 15 patients. But that was one of the first reports in our literature showing that, hey, there's something about immunoglobulins, intravenous immunoglobulins, that could be beneficial to our patient population with dermatomyositis. The reason why immunoglobulins were not approved by the FDA to the treatment of dermatomyositis at that time, even though the benefits were described in that study, is because that study was very small, included only 15 patients. But again, that was the first one to be published in our literature showing improvement against placebo. And when I mean placebo, I mean a medication that has no noticeable or no described effect on the disease. So other studies have been conducted after that one, and these studies are heterogeneous. Some of them have included placebo, some of them have not included placebo as a way to compare immunoglobulins, intravenous immunoglobulins. And these studies have shown overall some improvement in fatigue and pain in patients with myositis. Patients with myositis have also improved in fevers, in decreasing fevers or controlling fevers, improvement of arthritis, so inflammation in the joints were also reported in other studies. Some patients had improvement of shortness of breath, and that's important because, as pointed out in the questions here in the chat, this medication has been used by us in the rheumatology and pulmonary communities sometimes to treat patients who have ILD as well. And there are some studies that have shown that these patients may notice improvement of their shortness of breath or cough. And some CT scans may even reveal improvement of the inflammation in the lungs after a course of IVIG. IVIG has also been shown to be beneficial with patients who have decrease in swallowing because of myositis and hoarseness. So the ones who have weakness in those muscles in the pharynx and larynx related to the myositis may also benefit from this medication. And importantly, IVIG can be very helpful in the treatment of myositis for patients who need to decrease their dose of prednisone. As you all know, prednisone, it is a very effective and rapid acting medication, and one that we use very commonly in the treatment of myositis, including dermatomyositis. But prednisone, particularly in the long run, can be associated with several side effects. Diabetes, increasing blood pressure and cholesterol, brittle bones or osteoporosis, cataracts, increasing changes in sleep patterns. So some patients mention insomnia, increasing appetite, and even psychiatric comorbidities, depression, anxiety, irritability, mood swings or changes. So IVIG can be used to more rapidly decrease the dose of prednisone that patients who have more resistant disease may need to have their disease under control. And again, this is not only important for doctors, but also particularly for patients. Whenever we are treating myositis, we always aim to treat and keep the myositis under control with the lowest dose of prednisone possible, ideally not even with prednisone at all. And the IVIG can be an instrument, a tool to get us there. So as you can see, IVIG has been associated in many different studies with the improvement of several of those symptoms and signs that have been associated with myositis, including the myositis, and from all different kind of systems, constitutional ones, the ones related to joints, breathing, swallowing, muscle weakness, and rashes. And that's the reason why IVIG has always been a very interesting tool for the treatment of myositis. So I have a lot of, I'm bringing some, again, illustrations here to help us understand what is actually what are immunoglobulins. And I get this question a lot from my patients as well in clinic, because they get very confused of what kind of medication it is. So first of all, I want to mention IVIG is a blood product. So if you are a Jehovah's Witness, if you have any religious impediment to get blood products, this is something that needs to be thoroughly discussed with your provider. And because it is a blood product, it comes from the donation of whole blood. So whenever you or someone you know who comes into the blood center to donate blood, the blood is spinned, is centrifuged into basically two to three kind of components. Number one, we separate in the blood the red blood cells. And these are what we associate more commonly with the donation of blood. These are for patients who are severely anemic because of trauma, surgeries, or other underlying diseases and need blood transfusions. So this is usually what they get when they are going for blood transfusions. Part of the blood that is centrifuge, and is the plasma. Plasma is what we call the liquid part of the blood. And in here you have water, minerals, and proteins. The proteins being immunoglobulins at some point, at a part of it. And we have buffy coat, which is a funny way to describe the white cells in platelets. They're in the blood as well. So as you can see, this is a breakdown in percentage of how much of each of these components is in the blood. So as you can see, the plasma, the liquid part of the blood is 55% of the blood. White cells and platelets. White cells are the ones that are associated with our immune response, and platelets platelets are the cells that help us with clotting and preventing to bleeding. So these are a small amount of our whole blood, less than 1%, and the red blood cells are the other 45%. The immunoglobulins are proteins, and the immunoglobulins are dissolved in this plasma part of the whole blood. Okay, so one thing that is important, immunoglobulins is a fancy name that we use in medicine to describe antibodies. So anyone with a good functioning immune system produces antibodies since we are born. And these antibodies are directed to bacteria or viruses to protect us from infections. And these antibodies are what we call immunoglobulins, and they stay dissolved in this liquid part of our blood. Okay, so I hope I was able to provide you some understanding of what immunoglobulins are and how do we get immunoglobulins from the whole blood. After the donation and after the centrifuge of whole blood of many different donors, the immunoglobulins are then separated here from the plasma, and they are concentrated in this very concentrated packs of immunoglobulins. So they remove the liquid part of the plasma. They concentrate just those antibodies, just those immunoglobulins, and they are the ones who made IVIG, or intravenous immunoglobulin, as a medication that we use for myositis, and also to many other autoimmune diseases and to immunodeficiencies as well. So moving on, and again, if anyone has any additional questions about it, we can go back to it after the presentation is finished. So now that we know what immunoglobulins are, again, they are antibodies, they're diluted in the plasma, the liquid part of our whole blood. How do they work? Well, that's actually a very interesting question because we don't know exactly. We have some ideas of how do they work, and we believe that immunoglobulins are helpful for the treatment of many autoimmune diseases, including myositis, because they act from different directions. They actually have multiple mechanisms of action, and that's what makes them helpful in the treatment of myositis in general. So we believe that immunoglobulins work by blocking the deposition of antibodies in blood vessels. So let's stop here and just give you some perspective. So as you may know, some patients with myositis, particularly the myositis, they have what we call autoantibodies. Again, antibodies are those proteins that our immune system produces to protect us from infections. But some patients produce autoantibodies, antibodies that are actually directed to self, directed to their own cells. And these antibodies that are harmful and being produced by our immune system, they start depositing in the blood vessels. In these blood vessels are under the skin, these blood vessels and in the muscles, in the lungs. And we believe by that this deposition of these harmful autoantibodies in the blood vessels, that triggers inflammation. So the IVIG may block the deposition of these antibodies. And by doing so, it may prevent the pro-inflammatory cascade that comes after this deposition of harmful antibodies. And not only preventing the inflammation that comes from this deposition, but also it may also prevent the migration of inflammatory immune cells and that come afterwards to these tissues to propagate inflammation even further. By doing so, the IVIGs decrease inflammation in muscle fibers, inflammation in blood vessels, and also in the skin. And all this, again, very broad mechanisms of action from different directions turns immunoglobulins into a very potent immune modulatory agent. We say immune modulatory, not immune suppressant. And that's an important distinction that I would like to mention to you here. Immunoglobulins are not immunosuppressants such as prednisone or methotrexate or Celcept or azathioprine or rituximab. You may have been familiar. You may be familiar with these other immunosuppressant medications that we use for the treatment of myositis. That's not the case with immunoglobulins. And that's one more reason why immunoglobulins are so broadly used in our community is because these medications, immunoglobulins in general, may help preventing inflammation by doing all this that I have mentioned to you without compromising the action of your immune system, without making our patients predisposed to opportunistic infections. So let's say I have someone with myositis and that person has very severe disease, is on high dose steroids and other immunosuppressive medications, and this patient got a severe infection. Because of that severe infection, we can no longer, or at least for a specific period of time, treat this patient with immunosuppressive medication. So we discontinue the methotrexate, we discontinue the rituximab, or whatever immunosuppressive medication that patient is taking. And then we decide to start immune globulins, intravenous immunoglobulins, or IVIG for the treatment of these patients. And the reason why this may be one interesting option is because the immunoglobulins are not gonna make our patients, this patient specifically that I'm exemplifying here to you, more predisposed to infection. So that will be an interesting way through the immunoglobulin therapy to get their disease, the myositis, under control while permitting the immune system to fight the infection with the help of antibiotics, for example. Another interesting use of immunoglobulins, again, it is for patients sometimes who have cancer. And these patients who have cancer may not be able to receive different, again, immunosuppressant medications that we commonly use to our patient population. And because of that, we may use immunoglobulins because they are not going, the immunoglobulins will not immune suppress our patients any further. If anything, I want to mention here to you, immunoglobulins are used for the treatment of myositis and other autoimmune diseases, but immunoglobulins are also the medication of choice to the treatment of many patients with immune deficiencies, patients whose immune system is not working that well, and they need the donation they need the immunoglobulins to help fighting infections in the daily life. And because of that extra benefit of immunoglobulins in not being immunosuppressant, this may be an interesting option for our patients who have a immune compromising system. So, well, I talked a lot about the benefits, potential benefits and uses of immunoglobulins, but the truth is that, and you know that it's not all sunshine and roses. So we need to talk about side effects, right? As you know, there is no medication without any side effects, and this needs to be thoroughly discussed with our patients. Because in the end of the day, our patients are the ones receiving these medications. They need to be aware what to expect. One thing I would like to mention here, although immunoglobulins do have side effects, as any other medications that can be recommended to any disease, that doesn't mean that a patient will develop side effects, okay? Those are the ones that are listed more commonly with immunoglobulins, but does not really mean that every single patient who will receive immunoglobulins will develop those. Okay, so what are the most common side effects associated with immunoglobulins? The most common ones are headaches. So for patients who are familiar with migraines, it feels very much like it. Patients who already have migraines may have a higher risk to develop headaches following the immunoglobulins infusions. So be aware of that. And this is something that needs to be documented to your doctor. Younger patients seem to be more likely to develop headaches as a side effect of immunoglobulins. As part of the headaches, nausea can come along. So nausea and headaches together are the most common side effects associated with immunoglobulins. High blood pressure can happen during the infusion, right after the infusion, and then normalizes afterwards. The reason behind it is because immunoglobulins are very viscous kind of medications, and they go, again, intravenous immunoglobulins, they go through an IV when they're being administered. And that may cause the blood pressure to spike during the infusion or right after it. And some patients may have flu-like symptoms. They have tremors, rigors, they may have some mild fevers, feeling fatigue, and ones may even develop a minor rash that can be itchy. So those are definitely the most common side effects and ones that we see in a regular basis in patients who receive immunoglobulins. Even though those are common side effects, there are ways to effectively prevent them to happen. The most important one is keep hydrated. Again, these are very viscous medications, and they go through an IV. And in order to dilute, I would say, the immunoglobulins when they're coming in, the best way to do it is by hydration. So I always recommend to my patients before their session to drink a little bit more water in the 2 days before the infusion, so they have their hydration status in their optimal stage when they come to the infusion center to receive this medication. Sometimes even before the immunoglobulins are administered, we can do normal saline, some hydration through an IV before the immunoglobulins are given in the infusion center as well. Some patients may benefit from pain relievers or antihistamine. Those are anti-allergy medications, particularly if they have history of headaches or they have had already headaches with the medication, with the immunoglobulins infusions, and antihistamines if they have history of rashes or those rigor symptoms as well. That can be very helpful. We definitely recommend patients to avoid sun exposure, because as we expose more to the sun, what happens is that we get more dehydrated, we sweat a little more, and we are trying to do exactly the opposite when giving IVIG to our patients. We want them to be as well hydrated as possible before the infusion starts. Rest is very important. And a few things that we can do as patients are receiving immunoglobulins and doing every single infusion they do is decreasing the infusion rate. So some patients may notice that the headaches and nausea, high blood pressure, the flu-like symptoms, they usually happen if you are trying to rush the infusion. Therefore, if you slow down the infusion a little bit and infuse it for longer periods, for a little longer, a few hours instead of 2 hours, for example, maybe 3 or even 4 or 5, this decreasing infusion rate can prevent the side effects to happen. And sometimes, actually commonly, we trying to space out the infusions by a few days. So instead of having all the infusion given in one single day, we usually space it out between 2 to 5 days. The most commonly is spaced out in 2 days. So patients come to the infusion center 2 days in a row. But for patients who have more common side effects, who have developed side effects with their first infusions, sometimes we're trying to infuse it over 5 days. So it's a little bothersome to patients. They need to come to the infusion center 5 days in a row to have the IVIG infused, but at the same time, that can be extremely helpful to prevent those side effects. And sometimes that's all you need. Keeping well hydrated, decreasing the infusion rate, and spacing it out through so many days, sometimes it's all you need to prevent those side effects. So those are the most common ones. Normally, we don't discontinue the infusions if patients develop those minor side effects, even though they can be bothersome. And you should definitely communicate to your doctor if you're experiencing any of the side effects. Most patients do well despite of those minor side effects. And the benefits of the IVIG may be so important that we decide, again, through a very reasonable patient-doctor relationship and discussion, that the benefits of IVIG outweigh the potential side effects of this medication. And we usually continue the treatment even if those common side effects happen, especially because, as I mentioned to you, there are very simple ways we can prevent the side effects or remediate the side effects if they happen. Now, rarely, very rarely, some more concerning side effects can happen. Blood clots, legs, arms, lungs, or even strokes have been documented with IVIG. So this is something that can happen. As I mentioned to you, IVIG is a very viscous medication, and we believe that by being very viscous, it may increase the chances of blood clots. And if you have history of blood clots, you should definitely document and mention that to your doctor. Seizures can happen as well, and some patients may have a presentation similar to meningitis. They develop rigors and very stiff, painful neck following the infusion. Renal disease is very rarely documented as well. I would like to say that those side effects that I mentioned here are rare. They usually don't happen. And also, these side effects can be prevented by a good hydration and decreasing infusion rate, or spacing out, dividing the infusions over 2 to 5 days. Okay, so although they sound very concerning, those are rarely reported, and some of these easy preventable measures can be instituted before the infusions to prevent those side effects to happen. Now, let's talk about some of the limitations related to IVIG as well. So a few of them is that this is a short-lived medication. What I mean with that is that after the infusion, usually the benefits of the medication peak around 4 to 6 weeks after the first infusion. And after the infusion, it is clear this intravenous immunoglobulin is naturally cleared by your own immune system. The benefits may also be clear, right? So what I'm trying to say here is that some patients, after the infusions of IVIG, may notice flares following IVIG discontinuation. So this is not always the case. I definitely have seen several cases of patients who require IVIG just in the acute setting because they're having a flare, or they are just diagnosed with the disease is very active, they need IVIG for several months, and then we are able to sustain a remission of the disease with other medications. But some patients may notice flares after discontinuation of IVIG, and some patients require long-term repeated treatments with IVIG. So it's really case by case. Unfortunately, we are not yet able to say who will and who will not flare after the infusion, who will or who will not need long-term repeated treatments with IVIG, but this is something that needs to be discussed with your doctor and needs to be considered when starting this medication. This is a very costly treatment. So we estimate most cases are between $100 and $300 per gram of immunoglobulins. Usually we administer 2 grams per kilogram of body weight. Let's say 70 kilograms is our average American. In most cases, we infuse it over 6 months. So we're talking about 6 months of treatment, almost $300,000 for treatment of myositis. And this is not including all the infusion related expenses that come with IVIG. You need to go to infusion center, pay the nurses, and all the equipment and personnel they are associated with this, with a successful infusion. So I just want to mention here, this is a very costly medication. And this is one of the reasons why we are excited to have this medication finally FDA approved, because although this is costly, we as doctors, we believe that when well documented, when well used, IVIG, even though it's very expensive, can actually prevent more costs in the future by decreasing the amount of prednisone, by decreasing the disease activity. Patients may be able to function better and to use fewer medications in the future. And the control of the disease is something that, in my opinion, it is way more important than $300,000 per year. So if we believe that this medication is well indicated, again, having disease control is ultimately our goal, and it will have innumerous uncountable benefits for our patient and for our communities in general. One thing I would like to mention here is that, again, because this medication is a blood product, it relies on the donation of whole blood around the United States. That was in 2019 a national shortage. So we didn't have enough IVIG for all the many diseases that have been treated with IVIG in the last several years. And the number of diseases for which IVIG has been recommended has only increased in the last few years. So there was a national shortage in 2019, and there was some concern of shortage again because of the COVID-19 pandemic. But thankfully, that seems to be under control. But this is something we need to be mindful. And again, that's the reason why IVIG needs to be well recommended, because this is a costly medication and it is finite, right? It relies on the donation of blood products in the first hand. So we need to make sure that we're using this very expensive, precious medication wisely. So now let me tell you what finally granted the FDA approval of IVIG. So just now, recently this year, early this year, there was a presentation, the EULAR, this is the European Rheumatology Community Conference, early in 2021. And in that presentation, the prodrome from dermatomyositis was presented. And this study was also what we call placebo-controlled study, right? It paired IVIG in one group of patients to placebo in a second group of patients, and included 95 patients with dermatomyositis. Again, this is a much bigger number compared to the 15 patients that I mentioned to you from that first study in 1993. So after this study, as a summary, it was noticeable that almost 80% of patients who receive IVIG, compared to the ones who receive placebo, had at least minimal improvement in the overall disease activity. And we are talking about lung, muscle, skin, daily activities, functional status, compared to 44% of patients in the placebo group over only 16 weeks. So in 4 months, the number of patients who noticed at least a minimal improvement, so some patients had a much more significant improvement, was basically almost double the amount of patients in the placebo group in just 4 weeks of treatment. So these are, again, striking benefits documented with IVIG, and the FDA this time finally granted approval for IVIG for the treatment of dermatomyositis because of this study. The study was similar to the one done in 1993, but this time included way more patients, and this time used many different outcome measures. They are more, I'll say, well documented compared to the one in 1993. So what does it mean actually to have a drug that is FDA approved? So whenever we say, doctors mention, or you read in the news or listen from the news that a medication was FDA approved for any specific disease, what the FDA is saying is that this medication, it is considered safe and efficacious for that specific disease, and it can be marketed in the United States. So that's what an FDA approval term means. One thing that is very important is not because the FDA approved the medication that the FDA is no longer going to monitor for side effects. It's exactly the opposite. By approving a medication, the FDA starts a new stage in monitoring of the side effects related to the medication that is called post-marketing surveillance. So after this medication, any medication, we're talking here about IVIG, is approved by the FDA will keep a very close eye in any weird side effects that may happen as more and more patients are being recommended IVIG or any FDA-approved medication to treat their diseases in the real life, right? Because before the FDA approves the medication is used without approval and used in the setting of clinical studies. Now it's different. Now we have the general community, we have the real life patients receiving the medications, and any kind of side effects that are happening from this post-marketing period is being very closely monitored by the FDA. Most importantly, the insurance approval of any FDA medication is much, much easier. That clears the way for patients, doctors, and supporting staff to start a medication that is well recommended in a timely manner. How many of you have you been recommended to use not only IVIG, but other medications and have not been able to receive the medication in a timely manner because the medication was not FDA approved, and your doctor needs to go back and forth with insurances to have a medication approved for you. So this is costly, this is time consuming, this is extremely frustrating, and have an FDA approved medication makes everything easier from there. Also, FDA approval makes it much easier to get another indication, another FDA approval for the same medication in other diseases. So far, IVIG has been approved for dermatomyositis, although we have used antisynthetase syndrome, polymyositis, immune-mediated necrotizing myopathies. So that kind of opens a way, an easier path, I would say, to get it approved for these other similar conditions, I would say. So just one final word here before we start our questions and answers is that how can I help my myositis community? So we are talking about FDA and clinical studies. So as you know, myositis can be extremely difficult to treat, even with IVIG now approved by the FDA to the treatment of dermatomyositis. So whenever you are seeking medical care, consider enrolling in clinical trials. Consider at least talking to your doctor about clinical trials. So clinical trials are good ways to discover new ways to diagnose, evaluate, and treat diseases. And clinical trials are offered in reference centers of myositis here in the United States. So I will look for those. And again, this is a case-by-case conversation that a patient should have with their physician, but clinical trials may be helpful for patients whose disease is not easy to control with the standard therapy, and also may help our myositis community to continue to move forward and be able to approve all the medications in addition to IVIG for the treatment of myositis. And as I mentioned to you, immunoglobulins are come from whole blood, and therefore come from donation of blood by donors around the United States. So if you know anyone in your family, anyone close by who's willing to be generous to the medical community in general, donating blood can be an act of love and can be part of that. It can be a generous measure from anyone here in the United States and elsewhere in the world. Okay, so that's my conversation with you. I hope you were able to learn a little more about this kind of mysterious medication called IVIG, why we got so excited about its approval, and we're gonna get started with questions and answers now. Let me just finish sharing my screen. So let's see. I'm going by order here. So again, Marianne, we discussed a little bit about ILD. ILD per se is not yet an indication for IVIG, although it has been used, IVIG has been used for the treatment of ILD in patients with myositis, and this is definitely a medication that can be considered for ILD. Shona, I had a heart attack likely linked to IVIG. As I mentioned, this is a rare side effect and has been documented. What are the ways to use IVIG products and not suffer clots? So again, if you have history of clots, you should definitely mention to your doctor. Some doctors may even recommend anticoagulation medication to prevent those clots to happen. Keeping hydrated, it is crucial. And that's what I do with my patients. I space out the infusion longer than 2 days, sometimes 5 days. And I do a very slow infusion rate to prevent clots to happen. But this is a very important topic and one that needs to be discussed with any physician when you're planning to start this medication. What is your experience, Mike? What is your experience with IVIG, subcutaneous immunoglobulins? Yes, I have dermatomyositis and find subcutaneous immunoglobulins better overall. Still excited about FDA approved? Yes, absolutely, Mike. Oh, this is a very good question. So subcutaneous immunoglobulins are not yet FDA approved. However, I have also used subcutaneous immunoglobulins for the treatment of myositis, dermatomyositis including, and I find this can be a very helpful choice. And we don't have, as far as I know, any study comparing head-to-head the intravenous to the subcutaneous ones. But my anecdotal experience, that's what you asked, is that subcutaneous immunoglobulins seem to be very helpful for the treatment of myositis as well. Very good question. I'm glad you're doing well. Kenneth, do you have any information, statistics, or data concerning impact of IVIG on cellulitis, subcutaneous accumulation? I am 73 and progressively increasing accumulations of fingers. Yes. So IVIG, I suspect you're talking about calcinosis, which is the deposition of calcium underneath the skin. So IVIG can be used, and I use it, can be used for patients who have calcinosis. It is not yet FDA approved for this specific complication, which you know, Kenneth, that is very difficult to control, but it can be used. The data is kind of sparse. I wouldn't be able to tell you exactly what are the statistics, but I have seen patients who do very well with IVIG and patients who don't respond at all. So we don't know exactly why is that the case, why calcinosis in some patients can be remediated with IVIG compared to others, but this medication can be definitely used in this kind of complication. I would definitely recommend you to discuss IVIG with your doctor about it. That's a good question and one that is being currently actively investigated as we speak. Cindy, how do you know the donated plasma has healthy antibodies? Is it tested in the production? Good question. So we don't know what it means to have healthy or unhealthy antibodies. So when we are pulling IVIG, we are pulling all antibodies from many different donors, and we don't have a way, we actually don't measure what kind of antibodies they are there. So we don't know, we don't have the data. The truth is that overall, because we are pulling antibodies from many different donors, we believe that in average, being the average American, a healthy person without an immune disease, we don't believe that is statistically concerning that some of these patients may have autoantibodies. And overall, we have a good, equitable response to many different kinds of immunoglobulins from different pharmaceutical companies, from different preparations. So overall, the averaging of these antibodies coming from so many different donors seem to outweigh any concerns that some of these patients may have some autoantibodies or harmful antibodies. Very good question. Deborah, have you ever heard of many cases of ILD for MDA5 antibodies being chronic without an eventual rapidly progressing ILD? Definitely. Deborah, I do have patients who have MDA5 antibodies and have ILD, and whose disease and ILD is under control. So although, again, rapid progressive ILD has been described more commonly in MDA5 positive patients, we see patients who do well otherwise. Liz, my doctors have told me that insurance will not cover immunoglobulin therapies unless I have failed all other therapies available to treat dermatomyositis. Does a new designation by the FDA for this therapy change insurance coverage for receiving it? It may. I have already noticed that it is easier to get IVIG approved for patients who have not yet tried other medications, and IVIG is being used as a first-line treatment. So if there was a problem, the reason why you were not able to receive IVIG, if the indication of IVIG in your case is still there, I would definitely recommend you to talk to your doctor, because it may be easier to get it approved this time. Why are some of the patients prescribed both immunosuppressants and IVIG? Oh, very good question. And this is part of our daily life. The reason why that happens is because myositis sometimes is very difficult to control. And most patients will require 1, 2, 3 different kinds of treatment modalities to get the myositis under control. So we're talking sometimes about prednisone, IVIG, and other immunosuppressant medications, methotrexate, mycophenolate, azathioprine, rituximab. So sometimes we need to use different medications to get the disease under control. And some patients, just IVIG is enough. Some other patients may have more severe disease and require other medications in conjunction with IVIG. Does it work with polymyositis also? Very good question. Yes, so there are some studies showing that polymyositis patients who have muscle weakness may also benefit from IVIG, even though IVIG has not been FDA approved for dermatomyositis yet. We sometimes use for polymyositis as well. Do you know the status of the development of synthetic prednisone? I believe it should have less side effects. I don't know where we stand with that, and if it is associated or not with more or less side effects. Marianne, is it more effective to donate plasma and platelets than whole blood to help replenish IVIG supplies? Actually, when you are donating blood, it is very difficult to, in the blood donation centers, to separate right away those specific components of whole blood. So whenever you donate blood, usually you donate whole blood altogether. And then in the processing time period after the blood is donated, then those different blood components are separated and go to their specific indications. So whenever someone is donating blood, it's usually whole blood, and then the donation center takes care of it later on. Paula, was IVIG just FDA approved for dermatomyositis but not polymyositis? That's correct. It was approved so far for dermatomyositis only because the study that we described, the ProDerm study that was presented in the European Conference of Rheumatology earlier this year, only included dermatomyositis patients. That doesn't mean that we don't use IVIG for the treatment of polymyositis. And this is something I'll definitely recommend you to talk to your doctor. Again, we have been using IVIG since the 1990s to treat myositis. And although now it's a little easier to get it approved, That doesn't mean that we cannot get it approved for other indications, including polymyositis. How does FDA approval relate to subcutaneous IVIG for the myositis? Can you speak to IgA poor IVIG? Yes. Okay. And couldn't tolerate. Also, can you speak to antibodies for COVID in IVIG? Okay, so many questions here. So yet the subcutaneous immunoglobulin has not yet received FDA approval, but can be done. As I mentioned to you before, I have personally experience of using subcutaneous immunoglobulins for the treatment of myositis with success. So if there is any contraindication for a patient to receive IVIG, the subcutaneous immunoglobulin can be considered. And can you speak about IgA poor IVIG? So there are some preparations that remove IgA for patients who are IgA deficient. And this is definitely something that can be discussed with your doctor. And some changes in the treatment plan can be helpful in patients who have IgA deficiency. And can you speak to antibodies for COVID in IVIG? So there are some medications. They're not particularly IVIG. They're antibodies against COVID that can be used in patients who are high risk for severe COVID complications after they get infected. And these medications can be used for patients who have, for example, immunosuppressant or take immunosuppressant medications, have an autoimmune disease, and they get infected with COVID. So these antibodies, they are different from IVIG, can be recommended in this case. So as Cindy, as we discussed, IVIG, yes, can be used for polymyositis, although it has not yet been FDA approved for polymyositis. As someone with non-amyopathic dermatomyositis, I have been using IVIG on and off for 10 years. Yeah, that's the case. As we discussed, some patients may need long-term treatment with IVIG. It was the only treatment that worked well for me. There are many different providers of IVIG, and GammaGar was the only one that was on. Recently, the hospital infused center I got was the Flebogam. I didn't have any adverse side effects. That's wonderful. Again, it seems the IVIG has been working very well. And again, different kind of formulations from pharmaceutical companies seem to be comparable in terms of efficacy. Judy, should I be aware of any difference because of changing IVIG? Not necessarily. I have patients who notice a difference, and we're trying to be more strict about the kind of IVIG they're infusing. Some patients who don't notice any. So now that you have used GammaGar for a long time and was recently switched to a different one, I will monitor. Okay, if you develop any side effects, if you notice any difference, maybe you can consider coming back to the prior one. But if this one is working as well and it's not associated with any additional side effects, I guess it's being comparable. Deborah, I have had 3 doses of monthly IVIG so far, as I needed a high dose and I can get subcutaneous one. Okay, I may only need it for another month or 2 to lower prednisone dose. Exactly, this is one of the reasons why I use the medication. I've always had troubles with my veins and don't want to port. That's precisely the reason why most of the times the subcutaneous immunoglobulin is used instead of the intravenous one. What can I do to prepare my veins before IV placement? So hydration. Very, very important. I think if you are more hydrated, it's easier for you to find out where the veins are. Hopefully you can get the subcutaneous one if the IV placement is so difficult in your case. That's usually the case when I recommend subcutaneous immunoglobulin compared to intravenous, is because of IV access as well. I tried IVIG about 8 years ago and saw no change. That happens, unfortunately. I did it for 3 months. Should I consider it again? And what is the optimum trial period to say whether IVIG works or not? So as I mentioned to you all, IVIG, it is not a whole grail, it's not a miraculous medication by no means. Some patients do not respond to it. It is hard to say if you should try again IVIG. you need to discuss with your doctor. Usually IVIG works better when the disease is very active. So definitely discuss with your physician if there is any signs of disease activity that he or she believes would be well addressed by IVIG, and if IVIG can be considered again. We don't know yet why some patients respond to IVIG and some patients don't, unfortunately. Some myositis patients are hopeful that as time goes on, our IVIG treatments will provide us additional COVID antibodies. Your comments. So it could be the case. Again, it is hard to say because IVIG is being pulled by different kind of donors. Some of them may have COVID antibodies, but we don't know yet what is the threshold of COVID antibodies that will protect them against COVID. We don't know yet if those COVID antibodies kind of, as I mentioned to you, they are clearly all IVIG antibodies that come with IVIG treatments, they are naturally cleared by your body after a few weeks of treatment. So even if you receive COVID antibodies from a donor because of IVIG treatment, they will not last forever. They will still be cleared out. And that's one of the reasons why the vaccine is still recommended for our patients with myositis and immunosuppressant medications. Carol, in addition to the myositis, I was recently diagnosed with heart failure with preserved ejection fraction. How should I balance the need to hydrate before my infusions with my recommendation for my cardiologist to go easy on water consumption? That's a wonderful question. So it sounds weird, but sometimes what I have done is that I may recommend a more gentle hydration compared to someone who does not have heart failure. And I may recommend Lasix or water, a medication, diuretic medication following the IVIG infusions to, again, stabilize the hydration status. Sometimes if the heart failure is very severe, I may recommend patients to be hospitalized instead of coming to a local infusion center to get their IVIG done. The reason behind is because I want you to have close your eyes from our doctors for our in these cases to make sure that the optimum status, the hydration optimum status are there, that the patient is not volume overload or dehydrated and therefore in high risk for side effects. So very good question, one that you need to discuss with your doctor, and there are ways to adjust, fine-tune those recommendations for patients who have failed. Kathy, I have refractory dermatomyositis. I did subcutaneous IG weekly for 4 months. We did have to put on hold for increasing weakness and pain to return to baseline. My baseline is completely dependent on a walker, able to stand 2 minutes. Since then, I have slowly declined to where I'm depending 90% on a wheelchair. I have a round of rituximab since May. Also not sure if it was helpful. I currently am receiving weekly Solimedrol with prednisone, trying to reduce this to 60 milligrams daily. My neuromuscular wants to try subcutaneous immunoglobulin again. I'm concerned my baseline is so decreased that any decrease in ability, I will increase possibilities of falls and ability to transfer to the wheelchair. Your thoughts? Thank you. So as I mentioned, immunoglobulins work better if the disease is active. If that's the case, I would definitely recommend you to talk to your physician again. And for patients who have developed chronic weakness from the myositis or other myositis because their disease has been active for so long, IVIG may not be as recommended, as well recommended anymore. So this is something that is really case by case and should be discussed with your doctor as well. Ooh, we have 1 more minute. Let's see. I have volunteered for a clinical trial for subcutaneous injections, Balista for lupus, and I got so much better. After it was discovered that I needed IVIG because I have dermatomyositis. Subcutaneous was later approved, so I fully supported signing up for clinical trials. Absolutely. Again, especially if your disease is difficult to control, signing up for clinical trials may be beneficial to you and also to the community as a whole. The IVIG, the same monoclonal antibody. Oh no, so IVIG is not the same as monoclonal antibodies. Monoclonal antibodies are used, for example, in patients who have some patients with COVID COVID-19 infections as well. Those antibodies are the same type of antibodies. They are designed to be exactly the same. IVIG, it is a polyclonal, meaning you have all different kinds of antibodies. They're pooled together, so it is different. IVIG is a more heterogeneous pooling of antibodies compared to monoclonal antibodies. They're specific antibodies for a specific condition. Are donors still limited to Americans? I have heard that it was an effect of availability and cost. Oh, that's a very good question. I don't think that donors are limited to American citizens. I think if you are an immigrant in the United States with a valid visa, you can probably donate blood as well. I have SRP polymyositis, okay, and I have been receiving IVIG infusions for almost a year, very common. I started drinking coconut water during my infusions. I have not gotten since implementing this practice. I do not get any additional fluids intravenous by choice. Has the coconut water been discussed as a means of hydration for treatment? That's a good point. I have not recommended to my patients. Coconut water not only can use for hydration, but also as a way to replenish many different kinds of electrolytes and calories as well. So that's a good point, and one that can be helpful, as you said. That's great. I think this is a very interesting suggestion. Some can also do direct plasma donation at times for paid. That's true. Again, most donors donate whole blood. And again, sometimes they can receive some reimbursement as part of their donation. Well, it's 3:31. Let me see. Our session is still on. So let's keep going until someone drops our session. Let's see. It's common way to call it to make money. Okay. Marianne, our local blood bank here in Venice is asking for plasma, but not sure if they spin it in. So again, it really depends on the blood donation centers. Most people donate whole blood, and again, this whole blood is later on centrifuged and spinned and separating those other components that can be used for many different reasons. So I would definitely, if this is something that interests you as you donate blood, something that you can ask the blood donation center. Good to see you both here. Okay, hydration, vitamin C keeps. Yeah, that's a good question. I don't know about vitamin C. I know about hydration, but I will look into it. Maybe vitamin C will be an easier way to, if it really works, to avoid side effects. But as far as I know, hydration for sure. I'm not sure about vitamin C to prevent those side effects.
Hi, Dr. Ventura. Unfortunately, we do have to end the session for today.
Absolutely
Sorry
fine.
about that.
Hopefully, I was able. Sorry, I couldn't answer all the questions, but I hope I was able to again clarify the topic to our community. Thank you so much for attending this session, and it was a big pleasure. Thank you so much. Appreciate it.
Thank you.